here to discuss two posters. One poster on the real-world efficacy and also tolerability of off-label bezafibrate or fibrates in general for patients with primary biliary cholangitis. And I was presented a real-world study on the factors associated with the response to bezafibrate therapy in the Netherlands, embedded in their real-world Dutch registry. And the interesting finding, apart from that the tolerability was more of an issue than previously anticipated, with a cumulative stopping rate at 1 year of 24%, was that patients with cirrhosis, who are probably the ones most in need of optimal disease management, had a threefold lower chance of fulfilling the Paris 2 response criteria, which are defined as an ALP and AST below 1.5 times the upper limit of normal and the normal bilirubin at 1 year of therapy, as opposed to non-cirrhotic patients. So this is obviously an issue, and it shows you on both the tolerability and efficacy that there remains an unmet need for patients in need, and that's why it's so important that there are continuous clinical trial developments, and also with respect to PPAR agonism, we continue to try to optimize this therapy. But there was also another part of the poster that was interesting, because the Dutch PBC study group showed that there is an inverse relation between dichotomous response evaluation and continuous response evaluation. So patients with high ALP levels at baseline had low chance of reaching Paris 2, 12%, versus almost 80% in those with the lowest ALP levels at baseline, while actually their absolute decline in the ALP level was statistically significantly stronger in those with high starting levels. And also, if you stratified patients for their response on 1 year, and it was stratified for the Paris 2 response, patients who did not fulfill the traditional response criteria had a stronger decline in absolute terms of their ALP. And this is, I think, very important to realize for clinicians and also regulators. Now, all these dichotomous criteria are well embedded in the literature and also often the primary endpoints in clinical trial developments, but it's the absolute decline which is important for the patients. And patients should realize this as well. They should not be considering themselves as a non-responder, because if you consider the log linear relation between ALP and long-term outcomes of liver disease, it's actually those patients with the strongest ALP response who do not meet the criteria who benefit most. Those are the ones in which you prevent mortality, in which you prevent liver transplantation. So that is something to take along in clinical practice and inform your patients of the benefits. And obviously, if you do not respond, we need to further look into their needs and the options for extending treatment or changing treatment. But the term non-response should be something of the past. Now, in terms of alternative or further treatment options, there was also an interesting poster on triple therapy, or the addition of not one second-line treatment option, but combining two different drugs with a different mode of action. It was an INTERCEPT study, a phase 2 study, in which patients with an ALP above 1.5 times the upper limit of normal, total bilirubin kept at twice the upper limit of normal, as is normal in these type of randomized control trials, were randomized to 4 treatment arms of combination therapy of obeticholic acid with bezafibrate or placebo and bezafibrate. Multiple dosages of bezafibrate were used, but if you look at the standard dose, 400 milligrams once daily in combination with obeticholic acid, starting at 5 milligrams and after 4 weeks titrated up to 10 milligrams, there was a significantly stronger response in alkaline phosphatase as opposed to patients treated with bezafibrate alone. And not only that, there were up to almost 70% of the patients in this combination treatment arm reached a very stringent biochemical response criteria of complete normalization of all the relevant liver-related biochemical parameters. And that actually means and tells me that this complete normalization is really a realistic treatment goal in the nearby future. At the same time, tolerability was good. Not very different between the 4 treatment arms, and obviously we should still appreciate that the numbers included in this first phase 2 trial were small, but also pruritus, which has been known to influence the possibility to treat with obeticholic acid was not seen more frequently in the combination arm as opposed to patients who were not treated with obeticholic acid. So I think this is really something promising, it's something interesting. We still need more data, we need to detangle better which patients should straight on go to triple therapy and which patients might benefit from either obeticholic acid or a PPAR agonist alone. That's something for the future, but it is encouraging for patients, especially those who remain with high liver-related parameters suggestive of poor outcome, that the options for them are increasing as the field moves along.